Dr. Mylonas from Yale Cardiac Center, where he's a surgical resident, who's going to talk to us about what's new in the management of critical aortic stenosis, transcatheter versus surgical. So, Dr. Mylonas.
Thank you, Professor Anderson. Appreciate it. Good morning. First of all, I would like to thank Dr. Jifa and Dr. Mitropoulos for inviting me to discuss current updates in the management of critical aortic valve stenosis. I have no conflict of interest to declare. And without further delay, let's get right to the topic. As we all know, congenital AV stenosis accounts for approximately 70 to 80% of pediatric LVOT obstruction cases. Critical AS is typically accompanied by a spectrum of left heart defects, causing signs and symptoms of heart failure during the neonatal life. Irrespective, though, of clinical presentation, it is the severity of the obstruction that typically dictates treatment, with neonates exhibiting peak-to-peak systolic gradient greater than 50 millimeters mercury, requiring first immediate stabilization by keeping the ductus arteriosus open, and then some type of an intervention. Indeed, the initial goal of treatment is first to relieve the LVOT obstruction without causing, though, significant aortic regurgitation. With that in mind, several sites across the US and Europe seem to favor a balloon valvotomy as their first-line treatment because it does not require cardiopulmonary bypass, it has shorter hospitalization, and less immediate morbidity. However, this raises the question whether the long-term outcomes are really comparable between the two approaches. And what this landmark study from the Congenital Heart Surgeons Society attempted to do was basically compare surgery to BAV. And what they found was that although BAV achieves a significant reduction in LVOT obstruction with similar survival rates, the procedure carries nearly 5 times more risk of failure after the procedure. Following that initial study, several groups also published their experience in the matter, and Dr. Hill from Cincinnati Children's performed a meta-analysis consisting of 20 studies, including nearly 2,500 patients, to more robustly compare surgical valvotomy to balloon valvuloplasty for congenital aortic stenosis. And their most notable results are the following. First, both techniques seem to have about a 5% 30-day mortality rate. Second, the 10-year survival is also comparable between the two approaches, with BAV having a rate of 87% and SAV having a 10-year survival rate of 90%. That being said, the surgical approach was associated with significantly higher freedom from reintervention. Indeed, neonates that underwent surgical valvotomy, only in 25% of the cases required some type of reintervention within a median follow-up of 10 years. On the other hand, nearly half of the patients that were treated with the transcatheter approach required a reintervention within the same time frame. And this difference in outcomes between the two approaches might be even more exaggerated, considering the fact that in the majority of the papers, a more obsolete version of the surgical technique was utilized. It was about a transapical blind dilatation of the valve or a simple blade commissurotomy. Nowadays, however, surgical technique has evolved, and it includes resection of nodular dysplasia, thinning of the leaflets, recreation of interleaflet triangles by removing the fibrosis that immobilizes the commissures, and in certain cases, even recreating commissures utilizing pericardial patches. Now, all these tweaks in the surgical technique have resulted in a more durable result that may compensate for the initial invasiveness of surgery. Nevertheless, when debating between the two techniques, there are also certain morphological considerations of the valve that need to be taken into account. First, is the aortic valve unicuspid or bicuspid? Second, is there any maturity with myxomatous change of the cusps or any thickening of the valve cusps? And finally, is there any commissural fusion and/or hypoplasia of the annulus? Now, proponents of the surgical approach have utilized those morphological considerations for the following argument. They argue that ballooning causes rupture along the lines of least resistance, which typically means underdeveloped commissures or healthy cusp tissue. BAV does not seem to adequately address fused commissures or myxomatous thickened cusps and nodules. Therefore, ballooning can be particularly challenging in asymmetric valve cusps, unicuspid valves, and quite immature and myxomatous valves that have a lot of nodules. In these scenarios, BAV may cause non-reversible destructive damage because it tends to act on the best portion, the healthiest portion of the leaflet, leaving behind the thick and dysplastic part, and therefore preventing patients for whom simple repairs might be feasible from achieving an optimal surgical outcome. Furthermore, cardiac contractions and pulsatile blood flow may cause balloon displacement during dilation of the valve, and cardiac contraction against an inflated balloon can also increase wall stress and therefore result in myocardial and valvular injury. So to achieve balloon stabilization during the procedure, several techniques have been employed. These include extra stiff wires, long balloons and long seats, compliant balloons in the IVC and SVC, as well as bolus adenosine, which causes transient pharmacologic cardiac standstill. Last but not least, in recent years, rapid ventricular pacing has gained a lot of traction, and from now on, we're going to focus on that, because, as many series have shown, non-paced BAV patients require a lot of procedures after their initial dilation. Indeed, in this landmark study from Boston Children's, 1 year, the freedom from reintervention within 1 year was 65%. This declined to less than 50% in 5 years, and the decline was even more staggering at the 10-year mark, with a freedom from reintervention at about 25%. In light of these data, several centers across the US and Europe have incorporated rapid pacing as part of their standard BAV protocol. A very small subset of those centers have published their pediatric experience, and none had published their neonatal data. So, to fill that gap in the literature, our group here at ΜΗΤΕΡΑ under Dr. Jifa explored our own institutional data and attempted to kind of provide a structure for when and what are the outcomes when utilizing RRVP in neonates and infants. In all cases, a pacing catheter was placed in the right ventricle at VVI mode, and RRVP was used at about 200 BPMs until the systemic blood pressure dropped by more than 50%. The balloon to annulus ratio was chosen to be close to 1 but never above 1, and the balloon was inflated only after the pacing rate was reached and the blood pressure effectively dropped. Lastly, pacing was continued until the balloon was completely and utterly deflated. Now, neonates experienced a significant reduction in max gradient of about 40 millimeters mercury, and the only predictors of significant residual gradient at the level of the aortic valve were first, longer procedure time, and second, the history of any prior aortic valve procedures, which is not surprising. However, what's striking is the fact that their most recent echo, nearly half of the patients that underwent RRVP-assisted BAV had no aortic regurgitation whatsoever, and only 5% of this cohort experienced signs of moderate AR. No severe aortic insufficiency cases were noted in our series, and the only predictor of moderate aortic insufficiency was the presence of unicuspid aortic valve. And indeed, neonates and infants were not at an increased risk for notable aortic insufficiency after RRVP-assisted ballooning. It's also noteworthy that no interventions were required for patients that underwent the procedure as a neonate or an infant, and when looking at our entire pediatric series, the overall freedom from reintervention when RRVP was utilized was greater than 90%. That being said, the technique does carry certain risks, as with any procedure. Indeed, RRVP may lead to an increased risk of dysrhythmia in certain neonatal patients with a predisposition for ischemia or an underlying background of endocardial fibroelastosis. In our series, VFib developed in 3 neonates, 2 of whom had very echogenic mitral valve chordate A on admission echo, and the other had evidence of RCA thrombosis on the initial angio. All 3 of these cases were successfully cardioverted, but this is something that the practicing pediatric cardiologist should have in mind when attempting to utilize this technique. All in all, though, the results seem to be quite encouraging, and this raises the question, if RRVP-assisted BAV is so safe and successful, why hasn't it been more accepted on a broader basis? And the answer is simple. There is a predominant theory that low stroke volumes, higher neonatal heart rates, and occasionally low ejection fraction are unable to cause uncontrolled balloon movement and valvular damage. Nevertheless, this theory fails to explain why surgical bailout for post-valvuloplasty severe AR has been repeatedly reported for neonates and infants who were subjected to aortic valvuloplasty without the use of rapid pacing. And it is important, it is of paramount importance to minimize AR rates, to minimize the need for a ROS operation before the first year of life, because it carries a very high mortality rate of as high as 30%. All in all, there are certain key messages to keep from this talk. First, when contemplating which type of treatment to utilize in our baby with isolated critical AS, it is important to individualize care. There is no one-size-fits-all. So multidisciplinary boards, including pediatric cardiologists and pediatric cardiac surgeons, are necessary. Second, current surgical technique has evolved a lot from prior years, and this was in relation to the great historical review that Professor Anderson gave. And nowadays, current surgical technique can lead to an effective and durable result that, again, may compensate for the invasiveness of surgery in certain groups. That being said, in the majority of the centers, especially in Europe, ballooning still remains the first-line treatment for critical aortic stenosis. The technique has great results, but they can be further improved by the implementation of rapid ventricular pacing, which can effectively stabilize the balloon during the procedure, decreasing subsequent AR rates, and therefore, again, reducing the need for high-risk surgical bailout procedures in the first year of life, like the ROS or the ROS-Cono procedure. Last but not least, moving forward, it would be important to compare current surgical technique to RRVP-assisted BAV so that we can have a more informed and more well-rounded idea of what the current landscape looks like in the treatment of isolated critical aortic stenosis in the neonate. Thank you for your attention.
Thank you very much, Dr. Mylonas, and for keeping to time. I think in common with yesterday's presentations, we'll leave discussion towards the end.